Thank you, sir. Your floor is yours.
Thank you so much, Norma. Let me try and share the screen first and let me know if you see the full screen. I'm just sharing it now. Do you see my full screen now, Norma?
Perfect. That is perfect. Go right ahead.
Awesome. Thank you. Thanks for this wonderful introduction. And first of all, thank you for the invitation to do this talk. I mean, whenever you invite me for this, it's just an absolute pleasure for me. I mean, nothing excites me more than engaging with the community for which we are really doing what we are doing. And like you mentioned, I also want to thank everybody who has participated in the survey that is looking at the priorities for recovery in individuals with spastic paraplegia. And we're really looking forward to analyzing that data as well. I will talk about that survey briefly in the middle of this presentation, but what I'm going to focus today mainly on is early insights, early results, preliminary findings from the trial that we started a few months ago with the support of the Spastic Paraplegia Foundation. And that trial really looks at a non-invasive spinal cord neuromodulation for improving function in people with spastic paraplegia. I have no conflicts of interest. So really what I want to cover today is I will very briefly introduce neuromodulation, what that means. I will talk about some of our initial findings from cerebral palsy and spinal cord injury, what led us towards giving some confidence of trying this technique in people with HSP. I will talk a little bit about the survey data from the HSP population. I will then talk a little bit about the outcomes that we have assessed so far and analyzed so far in this initial phase of the study. And then I'll talk about the conclusions of the study so far. So we heard the word neuromodulation. What does it really mean? In simple terms, neuromodulation means altering the nerve activity, altering the activity of the cells within the nervous system using a targeted delivery of a stimulus. Now, that stimulus can be electrical, which is the focus of my research, but that stimulus could be magnetic. It could be light-based neuromodulation. It could be sound-based neuromodulation. It could be chemical neuromodulation. It could be mechanical neuromodulation. So all of the things, anything, any stimulus that changes the activity of a neuron, of a nerve, of nervous system, that is neuromodulation. The focus of my research is electrical neuromodulation, but I just wanted to give a broader context that neuromodulation is not just limited to electricity. Now, when we talk about electricity or neuromodulation, it sounds like a very fancy term. It sounds like a very modern medicine type term, but it's actually not that modern. If you look at the history, the first contact of humans with electricity is way before the man-made electricity came into place. The earliest findings is from 5,000 years ago from the Egyptian tomb paintings, where they show humans interacting with these electric fish, meaning suggests that they were aware of the electrical properties of this fish. About 2,800 years later, a Roman physician actually had the first documentation of treatment based on electrical current. They used electrical current from a torpedo fish to treat gout or headache. So that was the first medicinal documentation of neuromodulation. Now, what does it look like in the modern day medicine? So this is probably one of the earliest reports of spinal cord neuromodulation, meaning electrical stimulation of the spinal cord for treatment of pain in one patient. This was done in 1967 in Wisconsin medicine. And this study basically used an implantable electrical stimulator on the spinal cord for a patient to treat with pain. And what you're seeing here is a cross section after the postmortem. So this patient actually unfortunately died after 7 days of implantation, but they saw immediate reductions in pain, suggesting that there were some promising findings from neuromodulation. Fast forward now, present day neuromodulation can be done in two ways. One, which is showing right here, is the epidural spinal cord stimulation. Epidural means on the dura, on the spinal cord. This is surgically implanted electrode that is placed between the bone and the spinal cord. And the stimulator, that is the power generator, is placed somewhere under the skin. So that's one of the ways you can do spinal cord stimulation. It's very invasive, but it's also very effective. What we are really interested in is transcutaneous spinal cord stimulation, meaning can we deliver that same current through electrodes placed on skin without the need of a surgery. That's what we are targeting in our lab. And that's what we have been doing for spinal cord injury, for cerebral palsy. And now with the support of Foundation, we are moving this towards people with spastic paraplegia. So when you are using spinal cord stimulation for using a non-invasive approach, obviously it comes with some real obvious benefits. That would be, yes, you don't need a surgery. There is no need for implanting the electrodes. There is no need for a surgical procedure. And when there is no surgery involved, there are obviously much lower risk involved. Then if you don't need the surgery, the cost also comes to be very low. These electrodes are really cheap. You can buy them even on Amazon, and something that can be easily used in any setting. These are use and remove. An epidurally implanted stimulator cannot be removed in case of any complication, or let's say you change your mind or you think that it's not effective for me, you can't remove a surgically implanted device. At least in most cases, you cannot do that. But in this case, this is just a peel-off sticker. You can just remove it. The electrode placement can be customized. Maybe one location doesn't work for you. You'll see it in the CP studies that I show in future slides, that the electrode position can be modified based on what areas of the spinal cord you want to target. That is something that can be changed on a day-to-day basis in this type of stimulation. That is something you cannot achieve with a surgically implanted electrode. And also at the same time, it does not make you ineligible for some other studies. Like for example, if somebody has an electrical device implanted in their body, I cannot use them in my trials. They're ineligible because there will be some interference with what they already have. Whereas if we are using this type of stimulation, you can still become eligible for other potential more promising treatments as well, right? This is reversible. Some of the caveats, the electrodes need to be placed every time. So if you are challenged with your arm function, this is more applicable in people with spinal cord injury. You can't reach your back. You don't know where you're putting. So you need somebody to help you with this. And this needs to be done every time you're doing this. So that is one of the obvious challenge. And also somebody could question that when you're stimulating the spinal cord all the way out from the skin versus putting the electrode directly on the spinal cord, are you even precise enough? Are you really targeting the right pathways? And there are some studies that I wanted to show you about. One of them is how they looked at that. So this is an example of a study that compared non-invasive spinal cord stimulation through the skin with an invasive spinal cord stimulation, and they looked at the muscular activity. This is a study from Europe. What they did is looked at the EMG activity from the muscles in response to spinal cord stimulation, whether done through transcutaneous means, so TSCS is transcutaneous spinal cord stimulation, or epidurally implanted electrodes. And the way the study was designed, it was the same participants who initially got the surface stimulation. Some of them actually went ahead for an implanted device as well. So they could compare within the same patient the effect of surface versus implanted stimulators. And what this saw here, this is looking at 4 different muscles in the legs. And the top panel that you're seeing is basically the EMG activity in one versus the other, epidural versus transcutaneous. And what I really want you to look at in this busy figure is that they both look same. The intensity is very similar. The responses look very similar. The bottom bar graphs that you're seeing is basically talking about the latencies, how quickly the response comes after the stimulation is applied. So what they concluded from this study is, at least for this particular function, at least when looking at the muscle activity, which is very relevant to this population, these two types of stimulations are very similar in terms of the neural structures that they're targeting. Meaning you may get away with a non-invasive stimulator if you're getting the same effect. You don't necessarily need to go for an epidural device. Now, I'm not advocating for one versus other. I'm just trying to compare that, there is some evidence which is quite convincing to me that at least in this study, there is a similar effect of stimulation when even applied from the skin, which I think is a big deal. Okay, so why do we think that transcutaneous spinal cord stimulation can improve function in people with hereditary spastic paraplegia? This comes from our experience with patients with cerebral palsy, which is a condition that arises from injury to a developing brain. So this is a child with cerebral palsy who has difficulties even stabilizing their head, neck, and trunk control. So this is a very severe form of cerebral palsy. At the same time, I have done my graduate work and a lot of postdoctoral work in a condition called spinal cord injury, which you might have heard. This is a traumatic condition where is an injury such as a fall, accident, gunshot wound can lead to a damage of spinal cord at a specific area. And then depending on the severity of the lesion and location of the lesion, the person can have several degree of disability. And then obviously, this is not exactly similar, but it has some similarities to hereditary spastic paraplegia, where the descending control is also degenerating when the CST, corticospinal tract neurons, are degenerating due to these mutations. So when we saw some promising findings in cerebral palsy, in spinal cord injury, we thought it is a logical step to look at whether spinal cord stimulation can help patients with HSP as well. What are these findings that we saw in CP? So this CP work, I want to credit Dr. Parag Garg in collaboration with him and his company Spinex that makes these stimulators. We did some of this work, and the videos that I'm showing were courtesy of Dr. Garg. So this work has been published across multiple papers. I was fortunate to be a part of some of them, and I will show you some video examples from all these papers just to summarize for this particular presentation. So what you're seeing here is the same kit that I showed you earlier with CP. This is the most severe form of CP, level 5. And what you will see on this video is the effect of stimulation on sitting and head control first. So on the left side, you see scone off. Scone means spinal cord neuromodulation. And on the right-hand side, you see scone on. And you'll just pay attention to the head and neck control on this child, stimulation off versus on. You can see there is a lot more control on the right side. And this is essentially an immediate effect of spinal cord stimulation. So I hope you can appreciate the difference when stimulation is off versus on. There is a lot more voluntary control. So now let's switch to sit to stand. So now going from sitting position to standing position, again, left is the stimulation off, right is stimulation on. Try to see the attempts the physical therapist is making in making this child stand. And also notice how the therapist leg is supporting the child when they're standing in off versus on. So second attempt on the stimulation off because the first one didn't really work. And see on the right-hand side, there is no leg support anymore from the therapist. So this is one of the most severe cases of CP that you will see, level 5. If you look at level 4, so this is a child with level 4 CP. He does have head and neck control, trunk control, but there is inability to step. And on the left in this video is the stimulation off, and on the right is the stimulation on. And again, we are talking about the immediate effect of spinal cord stimulation in the child that is unable to step versus being able to step with the stimulation on. And this, as I mentioned, is a real-time effect. But in this child, he got several weeks of therapy after these initial assessments. And after several weeks of therapy, he showed some persistent improvement. So this video was shared by this child's parents to Dr. Gad, and he shared this with me. And they saw some significant improvement in this child with long-term stimulation. This was several weeks of stimulation after the initial sessions.
I have just got to say this. This looks like one of those things that Rodney said about wheelchair to bicycle.
Yeah, I remember.
I
remember that.
Yes. That just says it all, right?
Yeah.
That's phenomenal.
Absolutely. So CP in this case, it's obviously considered as a childhood motor disorder. It's one of the most common motor disorders that you see in children. But it's not just a childhood disorder. These children have a long lifespan thanks to medical care. they can live fairly long life compared to neurotypical individuals. So we decided to do this study in an individual who was 60 years old, was diagnosed with CP when she was less than 2 years old, and she has gone through a number of different therapeutic options throughout her life, including musculoskeletal surgeries, physical therapy, you name it. We had a whole medical history, and nothing really helped her. Even prior to engaging in this therapy, she had undergone 15 years of PT with really not much improvement. So, this therapy was 8 weeks of spinal cord stimulation twice a week, 1 hour a day. This was paired with physical therapy. Simulation was applied at the neck and the lower back. And what we saw in this case, in this woman, was this score on the left panel that you're seeing. If you can follow my pointer, this score is GMFM 88. It's an 88 item composite score of gross motor function measure. And higher the score means more improvement. So this is her score in the red before treatment. In the green is the score of 8 weeks of treatment. What you can see is that the green crosses this dash line. That dash line indicates MCID, which is the minimum clinically important difference. So it's not just a statistical significance. This is a single case. So we can't really talk about statistics here. This is more of a descriptive data. But what we see is this score has 5 different domains, all the way from lying and rolling to sitting to standing to walking and to running. All of them put together, when this score has a 5 point change, that means there is a clinically important change in this score. And this is what we saw with 8 weeks of stimulation. And that was maintained. What you see in blue, which is FU, which is follow up, that improvement was also maintained at a follow up, which was several weeks later. And on the right panel, you see some snapshots from this woman going from floor to sitting on a stool. Above panel is pre and the lower panel is post stimulation. And she had a greater success in going from floor to a stool after the stimulation therapy. Now, let me show you some examples from spinal cord injury. And I should also mention this, that spinal cord injury, in fact, has a lot more evidence of documenting efficacy of spinal cord stimulation than CP. I'm going to not talk about all of that. I'm going to just show you one example that was recently published from the laboratory of Dr. Andrei Krasikov. This work was led by Dr. Soshi Samejima, who's now assistant professor at University of Washington. I also wanted to mention that Dr. Krasikov is my postdoctoral mentor. Before moving to University of Kentucky, I was a postdoc in his lab. So this study was published recently. And in this case, we had one individual who had a spinal cord injury from a tree falling on his neck in 2012. And he was from cervical spinal cord. He was injured with a complete injury. So AIS-A that you see here is the highest, most severe form of injury, meaning he has no motor control. We are talking about no motor control. This is way more severe than what you see in HSP or the cases that I show you in CP. This person has no sensation, no motor control from his neck down. And what we saw when he was given 30 days of spinal cord stimulation, 30 or 35 days of spinal cord stimulation, 5 sessions per week, 6 weeks. So yeah, that's 30 sessions. And let me see if the video plays. Here you go. We asked him to raise his leg against gravity.
Without stimulation, right leg up, 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 and relax, and left leg up.
So in the absence of stimulation, he
Up,
cannot move his leg.
Relax.
There is no motor control.
Right leg up, 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 and left leg up. Okay.
Now, after 30 sessions of stimulation,
with stimulation, right leg up, up, and down. Good. Left leg up and down, and right leg up again. Keep up, and down, and left leg up and down.
So again, there is an important thing that I should mention here, is that this particular video that you're seeing, this leg raises, these knee extensions that the person is making, they are not triggered by stimulation. He's only doing it at will. This is a volitional motor control, meaning the stimulation is enabling his circuits to do something that the brain wants to do. We are not triggering muscle contraction by current here. That's an important distinction. And what I also wanted to show here is that this is an important scientific data point for us, but it means a lot more for this patient. I mean, look at this person now kicking a ball in the lab. This is a person with motor complete spinal cord injury. So it really, really tells us that, behind this, each of these data points, there is like a human life that we can really touch in this case, right? And what I also wanted to mention in this particular case is your spinal cord is not just controlling movement. It's controlling everything it innervates. That means non-motor function as well. So in this particular individual, we also saw improvements. As you can see, the title of this study says multi-system benefits of spinal cord stimulation. And we also saw that his bladder function improved. His bladder was more compliant, meaning it had less non-voiding contractions when it was storing urine. There was a better bladder storage. His bowel function improved. So he underwent a procedure called anorectal manometry, where a balloon is inserted in the rectum and inflated. And it looks at the coordination between the rectum muscles and the sphincters that control the anus opening and closing. And there was a lot more coordination in this individual after spinal cord stimulation. And his sexual function also increased. He got increased score in the erectile function questionnaire. And it meant a lot to him that he was able to get now reflexogenic erections. So this was one case showing effects of spinal cord stimulation on many systems within an individual. And there are many other reports in spinal cord injury and in CP as well, where spinal cord stimulation has really helped in improving function. So now that brings us to the topic for the day, which is looking at spinal cord stimulation in hereditary spastic paraplegia. And we are looking at non-invasive spinal cord stimulation, but I also wanted to give credit to the earlier studies that have been done, especially this one from Brazil. Norma, I know you know some of the names on this paper. I believe Dr. Franca is the one who also presented at the St. Louis conference. And what they did in this particular case, this was a 51-year-old female with SPG4 mutation. She started noticing symptoms with progressive difficulties for last 15 years, and she underwent an epidural stimulator implant. So this is the invasive type of stimulation that I was showing earlier. This is an actual picture from that patient on the right side, where the stimulator is placed on the lower back. What they saw in this particular individual, this is the real-time effect of stimulation. What you're seeing on this panel, if you can follow my pointer, all these images on the left side are stimulation off. This is the plantar pressure of the person when they're walking. And what you see on the right is the same plantar pressure when they're walking with stimulation actively present. And I assume you can appreciate there's a lot more gray on the left and there's a lot less gray on the right. What that gray means, it's basically, it represents that the foot is dragging before they can lift it off the ground. And they can lift it off a lot better on the right side when the stimulation is present. So that was a effect of stimulation when it was actively present. They also looked at the longitudinal effect of stimulation. So this is after 12 months. They looked at this spastic paraplegia rating score, which is again a composite score of disease severity and progression. And they saw that there was reduction in the severity of disease over time, at least in the first and 6th month. And they compared that to, I think, 14 or 16 cases of similar SPG4 mutation. So they saw some immediate effect and some long-term effect of spinal cord stimulation through epidurally implanted electrode. Now, what we want to do is transcutaneous spinal cord stimulation in patients with spastic paraplegia. And I want to take this moment to again thank the foundation for supporting this work. I also want to mention and give a shout out to Vivek, who's really the backbone of this trial, and he's been leading everything, all the day-to-day activities of this trial. So I'm glad that he's on the team. So in this trial, this is the trial design right now. It's a single arm trial. We don't have a sham group. This is a very simple, straightforward pilot study. We want to see whether 8 weeks of spinal cord stimulation twice a week, is it going to have any benefit in people with spastic paraplegia? So we are basically doing recruitment, we screen, we do the informed consent, we do baseline assessments. Then we do assessments at a mid-intervention time point, which is 4 weeks. Then we do assessment at the end of the intervention at 8 weeks. And then we do one more assessment after 8 weeks of ending the therapy, meaning to see if there was an improvement at the end of 8 weeks, did it last long enough? So that is the trial design right now. And this is the inclusion criteria. It's only recruiting adults at the moment, only recruiting people with HSP who have a clinical diagnosis. We hope to maybe expand it to PLS in future as well. The patients or participants need to have stable medications for at least 4 weeks prior to enrollment. They should be able to participate in all the study visits and assessments, whether with or without assistive devices. There are some tests that we can do with assistive devices and some that we need for them to be independent enough that they can do it without any device. And if they're ambulatory, they should be able to walk at least 10 meters because that is a requirement for some of the tests that we are performing. And if they're wheelchair users, we obviously remove some of the tests. But at this time, we were not very stringent in our inclusion exclusion criteria. We wanted to really recruit anybody who we can because there is not much evidence in this field of who this simulation is going to benefit. So that is one of the ideas. We want to understand from this pilot study, are there any more promising candidates than others that will respond to this stimulation? That will help us design this trial more effectively if we do a larger multi-center study in future. Right. And then obviously the last is they should have the capacity to provide informed consent and follow all the study procedures. So Norma, this is my progress report for this grant. We have 4 participants recruited so far. Number 1, he's almost finished. Tomorrow is his 16th week follow-up visit. Number 2 is in that follow-up phase right now. Number 3 is finishing his 8-week visits tomorrow. And number 4 is just recently started and we finished the baseline assessments. So we have 4 recruited participants at the moment. 2 of them are SPG 7, 1 is SPG 4, 1 is SPG 11. So there is quite a heterogeneous group at the moment. So in terms of outcomes, it is obvious that we want to look at the motor function. We want to look at the gait defects. We want to look at the spasticity. We want to look at balance, reflexes, fatigue, and the paralysis. But also, we want to look at the non-motor functions. Chronic pain, which has been documented, urinary urgency, bowel dysfunction, sexual dysfunction, and cognitive impairment. And I'm going to take a small detour again out of the HSP and going back to the spinal cord injury world again to give you an example of this study. So this is a study that highlights why we need to pay attention to the consumer needs. This is a study from Dr. Kim Anderson. She's a professor and also a person living with spinal cord injury for almost 30 years. What you're seeing here is a snapshot from her Google Scholar page, which shows her citations. And this is a study that she did in 2004, looking at the priorities of individuals with spinal cord injury. She asked these individuals, I think this had around 700 participants, and she asked them, what is your number 1 priority for recovery? And this paper has been cited 2,700 times now since 2004. This is one of the most important figures from this paper. So when you look at a person with spinal cord injury, the first impression that goes is that person is on a wheelchair. To an outside viewer, that person looks like he cannot walk. But when you ask these people, what is your number 1 priority for recovery? Most of them wanted sexual function to be recovered first. This is people with paraplegia. People with quadriplegia who have an injury at the neck level where hands are also impaired, they want the hand function back first. So that's a different outcome. But in this case, which is very similar to HSP population, this is paraplegia, meaning the lower legs don't work. The legs don't work and the lower body is impacted. They reported that sexual function is the number 1 priority. Bowel and bladder control is number 2 priority. Trunk stability was the number 3 priority. And walking, which we just assume that they want to walk again, because that's like the most obvious deficit. That was the number 4 priority in this particular survey. So based on this is the survey, we talk about the survey that Norma mentioned in the beginning of this presentation. This survey is basically looking at the priorities for recovery in individuals with HSP. And this was led by Makaira Ross, who just finished her master's in my lab. And she's right now going to analyze this data and push this towards a manuscript for publication. So in this survey, we started distributing this in December. When I first analyzed this data, we had about 136 responses, and Norma tells me now we have over 500. Thank you, Norma. And this is the first question we asked. What symptoms do you currently experience as a result of your HSP? And the responses we got were not entirely surprising. Obviously, maximum people responded walking and gait problems, muscle stiffness and spasticity, ataxia, which is balance and coordination. And there were also reports of physical fatigue, muscle weakness, and this is important. Urinary urgency was reported in 70% of the individuals. So it just tells me that we should not just focus on motor function. We should look at other consequences of HSP as well, if we can. So next question we asked was, what is your number one priority for recovery? And most people again said regaining leg function and movement, better coordination and balance, spasticity. So these were like among the primary outcomes for our study. We also asked them, while we were at it, we thought, let's ask some more important questions. So we asked them, what are your barriers to participation? I am a new researcher to this field. So these questions were really important for me to understand this field better. And I hope when we publish this, it also helps others too. So we asked them, what is your biggest barrier to participation in a clinical trial? And two top answers were transportation or travel difficulties. And the second one was not enough information or awareness about research opportunities. It also tells us that we need to do a little bit more in spreading awareness. And that's exactly what the foundation is also doing here. We also asked them about, are there any concerns about participating in clinical trials? They said the number one concern was that the trial may not be effective. They also were concerned about whether the condition might get worse. Will they have a new side effect, or the time commitment? So they were really weighing the risks versus benefits. So this was a bit of a mixed response, but still very informative for us. Okay, so coming back to now trial outcomes. So for our trial, we are looking at a number of different outcomes, and this is really since we are in an exploratory phase, we try to maximize what we can measure when a person is coming to participate. This will really provide us important information of what we need to measure when we go for a larger trial in future. So first test that I'm describing here is a timed up and go test. This basically measures mobility, balance, and fall risk. In this test, a person is asked to get up from the chair, walk 3 meters, turn around, and come back and sit on the chair. And we measure the time it takes for the person to complete the task. So that's the timed up and go task. Second, we are looking at their aerobic capacity and endurance during a 6-minute walk test. So the person is asked to walk non-stop for 6 minutes at their comfortable pace, as if they were walking in a mall or a grocery store. And we ask them to continue walking as much as they can. If they need break, they can take a break. And we measure the distance covered by them during this 6 minutes. We are also looking at the knee strength of these individuals. So this is an example of a machine that measures their knee strength. So we measure how much strength they can generate in their knee, whether kicking out or pulling their knee back in. So knee extension or flexion. We're measuring the strength of their knee and how fast they can generate that force. We are also doing some 3D gait analysis. So in this case, the person is instrumented with, I think, 35 or 40 different markers on their body. And those markers are read by the infrared cameras placed on the wall. And we can create a 3-dimensional map of that person's movement, all the joints location while they're walking, and the force plate on the floor tells us the ground reaction forces. So that gives us a measure of the balance as well. And using the same setup, we can also look at their sit to stand ability and again balance during that if they're able to do the sit to stand task. In addition to these tests, we are looking at their spasticity, which is done by a physiatrist in our department using a modified Ashworth scale. So in this case, a person is asked to lay supine on a bench, and then each of these joints in the lower half of the body are moved, and we look at the spasticity based on a predetermined criteria, and this is scored by the physiatrist. We are also looking at some questionnaires that are validated for assessing disease severity and progression. For example, spastic paraplegia rating scale or HSP SNAP, which is a self-notion and perception questionnaire. We are looking at questionnaires for bowel function. We are also looking at questionnaires for bladder function. And lastly, we are doing some more exploratory analysis by drawing the blood from these participants and looking at the changes in their metabolic markers or biomarkers for disease severity, which is being done in collaboration with Dr. Bass and Pierre Marini at Drexel University. So we are collecting their blood pre, during, post this trial and see if they see any improvements. Does that correlate with any change in the blood biomarkers? So this is more of an exploratory assessment at the moment. Now coming to the results. So I'm going to show you results from 3 participants. This is more, again, descriptive results because every participant is so different in their functionality. So we can't really take an average across the group. So I'm going to show you results, some of the results for each participant. So think of this more like a initial peek through the findings that we are seeing rather than a more conclusive claim. Okay. This is from participant number 1, who is SPG7. He's more on the high functioning side, but he had some spasticity. And what you're seeing in each of this graph is the joint that we looked for spasticity, TCS off versus TCS on. And you can see in at least 4 out of the 6 muscle groups, his spasticity was reduced within 1 session of stimulation. This is an immediate effect of spinal cord stimulation in reducing spasticity in this person. In terms of longitudinal effects, we looked at the distance covered by the person in 6 minutes, and that was also improved by 4 weeks and 8 weeks of stimulation. And his follow-up visit is tomorrow, so we'll know what 16 weeks look like tomorrow. Distance, time taken to walk across a 10-meter distance, 10-meter walk test, was also reduced, meaning he was faster with stimulation. This is again a longitudinal effect. And lastly, the time up and go test, the time taken to get up from the chair, go around a 3-meter distance and sit, it was also reduced over time measured across sessions. This is participant number 2. She was SPG4. She was probably one of the most highly functioning participants we had so far. So in most of her tests, we saw that she scored already high enough that there is not much scope for us to improve there. But we did see changes in the spasticity in some of her joints. So for example, hip adductors, knee extensors, knee flexors, and an ankle plantar flexion. It was improved with the stimulation being present. This is participant number 3. He has the complex form of HSP, which is SPG11. And in his case, when we look at the spasticity, we see reduction in the spasticity in the hip, both flexure and adductors. We saw no change in the knee extensors, slightly increased spasticity in knee flexors, and no change in the ankle. This was really interesting for me because there was something that I was not noticing, but the parents of this person, they noticed that change, and that was in their ankles. So even though the spasticity did not change, this is an interesting video that I wanted to show you guys, is his ankle rotation. So the range of movement in his ankle with stimulation off versus on. So let's look at the off first. And this is, again, this is the first visit. This is the real-time effect of stimulation. This is a person with SPG 11. Right ankle go. So this is the maximum range of motion he has in his ankles in the absence of stimulation in the first or second visit that he came. Left ankle go. Stop. And now let's look at the same thing with stimulation on. Can you go in the other direction with the same ankle? Yeah. Okay, stop. Do the same thing with the left ankle. I hope you can visually appreciate, even though we did not see a change in the spasticity in the ankles, the range of motion improved with the stimulation being present. And then we also see a change in his ability to extend his knee. Right. So if we look at the knee extension, this is again on the left side, spinal cord stimulation off, and we ask him to extend his knees. Knee up. So this is the maximum he can extend his knee without stimulation on the right leg. Relax. Same thing with the left one. Left knee up. Keep up, keep up, keep up. Okay, relax. Okay. So this was stimulation off, and now let's look at the stimulation on. Right leg up, 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 up. Keep it up. Keep it up. And relax. Okay. Then we do the same for the left. Left leg up, 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 up. Keep it up. And relax. Okay. You want to try both legs? So I asked him to raise both legs together. Okay. And he was able to do that as well. Up, 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 up. Keep it up, keep it up, keep it up. Keep it up. Hold for as long as you can. And relax. So we noticed that we were able to increase the range of motion in his knee as well. And when we tried to quantify this using a goniometer, looking at the angle change in TCS off versus on, there was a clear change in the range of motion. So in the red, you're seeing stimulation off, and green stimulation on. Left leg and both right leg, they both showed increased range of motion, again, within one session of stimulation. So these are the initial findings. All right, so that brings me to the conclusion for this talk. So I hope I convinced you that spinal cord stimulation through non-invasive approach can also show potential functional recovery and may have some long-lasting effect across various neurological conditions. This includes spinal cord injury, CP, and HSP as well. And we are hoping to use this to promote functional recovery in people with HSP and maybe in future in people with PLS as well. Our initial assessments demonstrate that this is feasible and in many cases effective in HSP. And we do need to focus on the consumer needs, which is where our survey comes into play. And obviously, when we get larger sample size, we do more comprehensive longitudinal assessments, we will be able to make more conclusive statements about what improved, what did not improve. Are there any meaningful, long-lasting improvements with spinal cord stimulation in this population or not? With that, I want to thank a lot of people who have supported this study, obviously starting with the foundation who really funded this work, Vivek, who's been doing everything on day-to-day basis in this study, Makaira, who started the initial survey and is still leading the analysis. Michael Saman lab is the biomechanics lab, who's helping us do all the 3D gait analysis, knee strength assessments, and many other gait-related assessments. He has all the right tools for those assessments. Dr. Patel lab is going to help us with the metabolomics aspect. PM&R clinicians are the physiatrists who are helping us do the modified Ashworth score for spasticity. And Dr. Bass and Pierre Marini at Drexel, who will be helping us with the biomarker analysis for the blood samples. And lastly, the study participants and the caregivers who are really putting in all the effort in bringing them twice a week to our lab for these trials. Thank you, and I can take any questions now.
That is absolutely amazing. I love seeing that last screen. Now, I've got a lot of questions and thoughts, for everybody to also want to participate, but just having, all those people together working for HSP and what's going on here with, all these other diseases, you've assembled a really nice team there. So thank you so much, Rahul, for putting all this together. And Dr. Boss and Vivek, I know you guys are on screen or you're on the call as well. And thank you for very much as well as putting all of this together and getting it to this point. I see work ahead, but my goodness, it is amazing how much progress has been made in the realization of how this technology can make a difference. So hang on, I got a bunch of questions here backing up on us. Miss Barbara, I think you're first in line. Go ahead. You got a comment or a question?
Question. So I actually watched your presentation at the conference. I watched it online and I was super impressed by the work that you've done. I think this is a really great research study. What really stood out to me, what you said at the conference, and these numbers may not be exact, but I think you said you were looking for like 12 to 15 participants, but at the time you only had 3 participants in the study. So what went through my brain is why the gap, which my guess would be the location, Lexington, Kentucky. I know I had reached out to you and you mentioned that I couldn't do it just because of location. So with that being the case and being that it is transcutaneous, you're basically somebody's putting the electrodes on the patients. Is there any way that you would be able to train other doctors, PAs, medical students in larger markets to place the electrodes and transmit the data? This way, a larger population can participate in the study.
Yes, absolutely. I think that's a very, very important question, and I'm glad you asked that question. So this is the conversation we were just having before this presentation started, before all of you joined with Norma. And this is absolutely important for us to make sure that this reaches to everybody. The goal of this trial is to first understand whether it's effective, whether it's safe in this population, that initially it looks like it is. In terms of the number, we have just started recruiting. So it's only been 3 or 4 months. I believe we started in February or March. So we are actively recruiting. The goal for, like you saw, I had a laundry list of outcomes that we have listed here. And some of them are very, very specific to what we can do here. So if we were to do this as a larger multiple center trial, we cannot do everything everywhere. So one of the things we wanted to get from this initial screening type of trial is, are there specific type of people who respond better? Are there certain outcomes that are more sensitive that we can gauge some recovery? What are the most important outcomes that we need to spread across and that can be reliably done across centers? So all those type of information will come out of this trial. Now, to answer your second question about having it reach more people, the goal that I have in mind is to reach out to potential funders like NIH, maybe foundation in future. Once we have some efficacy established in our hands, where we can conclusively say that, yes, it is worth trying more, then we go for a larger trial where we, like exactly you said, bring somebody in lab with their caregivers, train them, make sure it's working for them, make sure they know how to safely use the device, make sure they're putting it at the right location, and then send the device home and let them stimulate on their own. That would be like a next project for me. I'm just basically giving you grant ideas for the future, essentially. But that's exactly what we are thinking. So I hope that answers your question.
Yeah,
I
I mean,
think
what I loved about it was you had mentioned in the conference that it wasn't just targeted towards the leg spasticity, but some of the more complicated symptoms as well. So it just seemed like a very well-rounded study that I personally got very excited about. And would, if I had all the, when I win Lotto, I'll come to Lexington twice a week. But, until then, I can get to Philly, I can get to, Columbia. And if my doctors could be trained, and, I don't mean to minimalize the complexity of what it is, and I might be, and correct me if I'm wrong, but if somebody can be trained to do that and then transmit the data to you, and then you have this huge data pool,
Yeah.
but it's really being put out to a large pool of people, and I feel like a lot of people would be very excited to
I
participate
feel like you
in
should just write my grant for me. You're describing is way better than I would do it.
Well,
So
and
that's
Barbara,
exactly what we are thinking.
the thing about it is this technology is going to be available. That's what is, that's what we're doing is we're establishing the base. We're establishing, the relevance. And what if you just get on Amazon and buy you one? Okay. So
Right.
let's just, that's what we would hold out for. Right. And that would be
Absolutely.
fantastic. So we've just got it. We're doing all the pre-work. We're doing all the pilot work to make sure that, some of those devices can be made available for families. That would be just absolutely remarkable. Miss Jackie, you got a comment or a question? Go ahead.
I have a whole bunch of questions, but I'll minimize it. Can I have the InterStim bladder stimulator, but I have a little device that I could turn it on and off. Could I do this treatment
That's a great
if I
question.
turned off my device?
So as of now, in our particular trial, any implanted device leads to an exclusion from this trial
Does
because
that
we
include a fusion, a back
exclusion
fusion?
any implanted device
Okay.
will be qualified for an exclusion from the trial. Meaning, if you have an implanted device at this point, you will not be eligible for this. Having said
Okay.
that, I would also like to mention that there are people who are willing to try that, and that is a decision your care provider would make. I'm not a clinician, I cannot do a clinical advice here, but this would be a decision if you had the device at home and you talk to your provider. The same thing applies for baclofen pump. I know many of the people with HSP or other spasticity related conditions have intrathecal baclofen pumps implanted. Some people, especially aging population, would have pacemakers in their body. So is it safe for them? There is some evidence that it shows that it's safe. There is a study published from Kessler Institute in New Jersey, led by Dr. Kirschblum, I believe, in spinal cord injury individuals. They looked at stimulation with in patients with a Medtronic intrathecal baclofen pump. And they showed that there was no evidence that it affected the functionality of the pump. Now, whether that same thing applies to the stimulator or any other implanted device is a question for the future. And that is a question that has to be systematically investigated. But at the same time, if you had the device at home and your care provider makes that decision for you, I think that is probably doable. But
Well,
that's not a decision that I could, or I cannot comment on that essentially.
correct. If this was available, though, it's no big deal to take the bladder stimulator out if
Mhm.
that helps the bladder. I
Mhm.
would definitely, I'll take it out myself.
Thank you,
Exactly.
Jackie.
Yeah.
Miss Theo, do you have a comment or a question? Please go ahead, Miss Marcia.
So basically, I've got the Molly suit, which provides the electrical stimulation, contains 28 electrodes, and I get a lot of benefit from that. I was wondering, how different is this to that with the electrical stimulation?
And so if I understood your question correctly, the one that you're using is a muscle stimulator, right? Like a TENS unit?
Yeah, yeah.
Where do you place the electrodes?
So, well, it's a suit.
I see.
So it's got 28 electrodes in. So some are on the back,
Mm-hmm.
some on the legs. So it covers all the muscles,
Yep.
basically.
So what you are doing is essentially exactly what I mentioned during the CP presentation is this is different from that stimulation in the sense that the stimulator that you are using is directly targeting your muscles. It is making your muscles contract. It is stimulating your muscles directly. So it is it's triggering your muscle contraction. What we are doing is we are targeting the current towards the spinal cord. And
Okay,
that
but
is more towards enabling movement.
yeah, it reduces the spasticity, so it turns the muscles off to a degree with the Molly suit.
Mm-hmm. Mm-hmm. So your question is, can this be combined
But
with that,
not
or
but not directly to the but it doesn't work directly on the spinal cord.
yes,
That's
yes,
the difference.
yes, that's the difference. So they are similar in the way that they both have
Yeah.
electrical current. The difference
Yeah.
is probably the type of stimulation parameters that the FES or that suit that you're using uses versus this one. This is designed in a way that it is made to penetrate deeper without causing much pain or without burning the skin so that it can reach the spinal cord. Whereas the stimulators that are used for muscle, they are more superficial. So the type of current that they generate is slightly different.
Okay.
So
Thank you.
it could be that you wouldn't use them together, but
I
you
believe
one day and maybe use the other on other days, to get yourself back up and going, right?
I believe there are studies that have combined FES, which is functional electrical stimulation, or like a TENS unit, with
Oh yeah,
spinal cord stimulation.
Okay, good to know.
the Molly suit isn't the same as the FES because I've got FES and that stimulates the muscle, whereas the Molly suit just has a gentle tingle.
Yeah.
But again, it doesn't activate on the nerve, it does stimulate nerve pathways, but it won't activate on the spinal cord.
Right. That's the difference.
Yeah.
It's very good. Thank you for pointing that out because I hadn't thought about it like that till we're talking about it. Jackie, you got a comment? Sherry, you're stacked up and it's still, I come back to you. Go ahead, Miss Jackie.
Where exactly do you stimulate? Because I've got like S1 through L3 fused. So just, is it thoracic?
It's above that. So we are targeting the lumbosacral spinal cord. That
So what,
corresponds to, if you look at the vertebral bodies, it's T11, 12 and L1, L2.
so
we put
what,
two
why
electrodes.
would a fusion eliminate somebody from doing it?
I'm not saying it would. I'm just saying that I don't know enough to do this.
Okay.
That we don't know. For us, safety is the number one priority. So
Okay.
we want to make sure that this is a preliminary study. We want to make sure that we are safely able to do this.
Okay.
Can I add a quick thought about that?
Mhm.
I just
Go
want to make it clear to everybody that what Rahul is doing is a study, and he's got these very narrow criteria for who can participate in the study so that he can get interpretable data that will help everybody.
Okay.
So the exclusionary criteria are for the study, but that doesn't mean that if you don't fit the criteria for the study, that the device won't be helpful to you. So the people who are participating in the study are doing everybody a service by providing this interpretable data. But the vision is that one day this device will be either at clinics all over the country, or hopefully that the price will come down or insurance companies will cover it, and that everyone can have one in your own home. That's the vision. And I personally think that this is so incredibly wonderful because Rahul and his team are brilliant. They are really, really good. And I'm just so
I love
happy
it.
he's involved in this and he's leading such an effort. He's just such a scholar and such expertise with all of this and such a caring, wonderful gentleman as well. And Vivek and the entire team as well. So I know that people sometimes have a little bit of good luck with the baclofen pump or with other kinds of therapies, but what this community really needs is something that will make the quality of your life better and soon. And this is what that does, you know. So we have long-term hope that gene therapy and intrabodies and ASOs and repurposing drugs will one day get at the mechanistic basis of the disease. But we're also very cognizant of the fact that this community needs something soon to improve the quality of your life. And I think that this is what this neurostimulation is. So I'm extremely enthusiastic about it. And I just want to make it really clear that if you don't fit the criteria for the study, it doesn't mean that this technology won't be available to you. I think as far as I know, maybe Rahul can talk about this a little bit. There's no negative effects. You know,
Absolutely. So I think you really beautifully summarized this, Dr. Bass, and thank you for doing that. Yes, there are some studies that have mentioned like some negative effects, like a burn mark on the skin if the stimulation is too high. I think there's like one out of probably several dozens of reports that there was one person whose bladder was not behaving the way it should behave in response to stimulation, something like that. But that compared to most of the side effects we see from other procedures, it's negligible. I just want to add that like it is. I'm not saying that there is no side effect, but the side effects are so minimal compared to the benefits that you get out of this.
That you guys, y'all are summing this up so well. But I have to say, Dr. Boss, that all the wonderful things that you said about Rahul and his team and all the brilliance, I could say that about you too. So now
Absolutely.
you
I
guys are
second that.
collaborating, which is one of our goals that we at the foundation have wanted now for years, is for people to collaborate and to find ways to get to something quick, to champion cures. That's what we were talking about, and wellness and therapies and all of those things. And I thank you so much, Raul, again, for being a part of this. Go ahead, Estelle, you got a question or comment?
So my only comment is about how doing the study remotely would be of benefit. So at the University of Plymouth, they're starting a Molly suit research in October. So University of Plymouth, that's in the UK, and it's being done remotely because people aren't able to travel in. And also when people travel in, you're getting different results because by the time somebody's traveled, they become more stiff.
Yeah.
So there's them issues around that as well.
Yeah, I 100% agree with that. And that's where these survey-like studies are important, because one of the things that was a biggest barrier that we found in this particular survey is barrier to participation was the transportation difficulties. People have to travel longer distances, and then that becomes more difficult when you have a disability. And I think if we are able to deliver something at home, we might be able to get good benefit, at the same time less cost to the patient in terms of both financial and the travel burden.
Yeah.
Raul, you have any other comments? You can have the last word, sir, before I shut it down.
I just want to say thank you to everybody for the time and the invitation to do this. I'm really, really grateful for this opportunity. And if anybody has any questions about this device or anything in general about research, please don't hesitate to send me an email.